Thank you, Dr. Richardson. May I invite the next one, Dr. Wu, to talk about the testing for azole-resistant Aspergillus, please.
Thank you very much for invitation to share the topic of testing for azole-resistant Aspergillus. This is my disclosure. I would like to begin with introduction of azole-resistant Aspergillus species, followed by testing for azole-resistance, including indications, phenotypic method, genotypic method, and proteomic method. Okay, the most important azole-resistant species to mention is Aspergillus fumigatus. Invasive aspergillosis due to azole-resistant fumigatus is a life-threatening disease with high mortality. And Dr. Sharon just mentioned that fumigatus was put on the WHO list of critical group of fungal pathogens. Azole-resistance in fumigatus may develop through exposure to fungicide in the environment, that is environmental resistance, or during patient therapy, that is patient-acquired resistance. And for environmental resistance, the CYP51A mutation, tendon repeat 34, and tendon repeat 46, along with amino acid substitution in CYP51A is the most prevalent resistant mechanism. So TR34 and TR46 related resistant genes are usually used as the main genetic target for detection of azole-resistant Aspergillus. And the other important species to mention is those with acquired azole resistance or intrinsic azole resistance, or Aspergillus flavus with acquired azole resistance due to a single point mutation in CYP51A has been reported. And about the intrinsic azole resistance, the European Acme guideline, Aspergillus guideline, pointed out that Aspergillus calidus and Aspergillus lentulus, which belong to Aspergillus fumigatus complex, are intrinsically resistant to azoles. So therefore, azole monotherapy are not recommended for treatment for IA due to Aspergillus calidus or Aspergillus lentulus. And MIC value of azoles is also informative for treating azole aspergillosis. For patients infected with fumigatus with voriconazole MIC of 2 milligram per liter, the Acme guidelines suggest that voriconazole and echinocandin combination or liposomal M4B monotherapy are strongly recommended for treatment. For isolated with voriconazole MIC higher than 2, liposomal M4B remains strong recommendation. However, voriconazole and nitrofurantoin combination become moderate suggestion. For isolated with even higher MIC, more than 8, the voriconazole and candin combination, the synergistic effect may be disappear, so the combination would be less beneficial. In clinical practice, what's the indication for testing azole resistance in Aspergillus? The Acme guidelines suggested that clinical relevant Aspergillus isolate from patient group or region with known azole resistance, or from patient not responding to azole treatment. We should test the isolate for azole resistance. It is also important to conduct resistance surveillance to determine the local epidemiology of azole resistance. To detect azole resistance, we can identify the isolate to species complex label. We can also do reference MIC testing to detect azole resistance. And the academic guideline, he also recommend methods for azole-resistant testing, including azole-agar screening test and reference and MIC testing using both microdilution and yeast test. For all clinical Aspergillus fumigatus isolate, when antifungal treatment is considered, we can use the azole-agar screening test first, followed by reference and MIC testing. But it should be noted that for mis-susceptible and resistant colonies could be found in 20% of clinical samples. So when we can azole-agar screening test or MIC testing of multiple colonies, up to 5 colonies can be tested. Okay. For reference MIC testing, we can use the UCAST method or CLSI method. And UCAST method is strongly recommended, grade A recommendation. It provides clinical breakpoint to define susceptible and resistant isolate. And CLSI method, it is moderately recommended. It provides epidemiological value to define wild type and non-wild type isolate. And e-test method can also be used for MIC testing. It is marginally recommended for MIC testing of various Aspergillus species. For azole-agar screening test, UCAST has proposed the document, the protocol for azole-agar screening test last year. And this test consists of a 4-well plate which contains agar supplemented with itraconazole, voriconazole, posaconazole, and a drug-free control well. And we can take multiple colony from a patient culture, and at the same time, and into a single 4-well azole-agar plate. And after 1 to 2 days incubation, colonies that grows on any of the azole-agar plate, like this one, are considered potentially azole-resistant and should be subjected to reference MIC testing using broad microdilution method to confirm azole resistance. So far, there's a CE-approved azole-agar screening assay. VIP check is commercially available. VIP here stands for voriconazole, itraconazole, and posaconazole. And alternatively, our laboratory will prepare the azole screening agar test by ourselves. But the azole concentration we use are a little lower than the concentration that UCAST recommended, so that the isolate with borderline resistance will not be missed. And we can, for testing, the isolate were inoculated on the drug-free control well. Yeah. So, and also into the 3 azole-agar plate, supplemented with itraconazole, voriconazole, and voriconazole. After 1 to 2 day incubation, both yes. And we can test many isolate simultaneously on one plate. It may be cost effective if there are several isolates to be screened. For example, we inoculate isolate A and then B onto the drug-free plate and 3 azole plate. After 1 to 2 day incubation, isolate A and B are supposed to grow on the growth control drug-free well. And isolate B, it did not grow on the azole-agar plate, so it was considered azole susceptible. But for isolate A, it grows on this azole-containing agar, so it was considered potentially azole-resistant and should be subject for reference MIC testing using broad microdilution method to confirm azole resistance. For reference MIC testing, Both UCAST and COSI method, they provide detailed laboratory procedure for MIC testing using more Bose microdilution method. The latest UCAST UCAST document for sustainability testing in mold were published in published last year. It can be downloaded for free from the website. To interpret the MIC UCAST proposed epidemiological value to classify wild type and non-wild type isolate. But importantly, UCAST also provide clinical breakpoint to define resistant isolate and susceptible isolate and resistant isolate for major Aspergillus species, including Fumigatus, Flavus, Terrace, and Niger and Nidulans. Okay. Take Aspergillus fumigatus, for example. A fumigatus with voriconazole MIC higher than 1 are considered voriconazole resistance. COSI M38A3 document is the latest reference method for Bose microdilution of net fungal stability testing of filamentous fungi. It is published in 2017. COSI also provide ECV for major Aspergillus species, including Flavus, Fumigatus, Niger, Terrace, and versicolor. But so far, COSI only provide one clinical breakpoint. That is voriconazole clinical breakpoint for Aspergillus fumigatus. And isolate with Aspergillus fumigatus with voriconazole MIC higher than 2 or equal to 2 are considered voriconazole resistant. And this value is similar with the voriconazole clinical breakpoint proposed by UCAST. So the procedure for COSI Bose microdilution are briefly illustrated here. To begin with, Aspergillus isolate for testing is subcultured on a PDA plate for 48 hours or until good sporulation. Then a sterile swab touch the colony surface, and then we make a conidia suspension adjusted to a standard inocular density. Because Aspergillus will produce large numbers of airborne conidia, so the procedure should be performed in a Class 2 biosafety cabinet. Okay. Then the conidia suspension are inoculated into the prepared antifungal drop panels with 240 dilutions. And the MIC of azole are read after 48 hours incubation. So the MIC of azoles determined as the lowest concentration which prevent any visible fungal growth, that is 100% inhibition. In the meanwhile, we should also plate the conidia suspension onto an agar plate to count the colony number to make sure that the inoculant density is appropriate. Okay. So this list table compares the difference between the UCAST and the COSI method. First, the UCAST used the flat bottom microplate well, and the COSI used the U-shape bottom, the microplate well. And for the broth medium, the UCAST used 2% glucose, and while COSI used 0.2% glucose. And UCAST used a bit higher inocular density than COSI. And for both methods, the endpoint for MIC is no visible fungal growth. Yeah. So, because in addition to no fungal growth, we can view to check to read the MIC by our naked eyes. Yeah. In addition to visual reading, because the UCAST method used the flat bottom well, so we can also use the spectral photometry for Aspergillus fumigators to determine the UCAST MIC. And finally, the UCAST, it has the advantage of providing clinical breakpoint for 5 major Aspergillus. For CLSI, currently only 1 breakpoint. This is work also for fumigators is available now. Although there are some difference between 2 methods, earlier study revealed high essential agreement between the azole MIC determined by CLSI and by UCAST. Okay, but because UCAST and CLSI method, reference method are laboratory intensive, so it is practical to have some other time-saving alternative to Aspergillus MIC. And 2 commercial assay, East1 micro-dilution plate and E-test strip are 2, it can be used as easy to perform alternative for MIC testing. East1 plate are pre-coated with 9 antifungal agent. Studies demonstrated that there is high essential agreement between azole MIC value used East1 and CLSI method, which are more than 90% for itraconazole, voriconazole, and pasaconazole. For the E-test method, the essential agreement of MIC value compared with the CLSI method was 83% for itraconazole and 87% for voriconazole. As mentioned earlier, E-test method is marginally supported by the ECME guideline for azole-resistant testing in various Aspergillus species. Since about half of patients with aspergillosis might be culture negative, alternative we can try to identify azole-resistant aspergillosis by molecular detection of azole-resistant gene directly on clinical specimen by using in-house or commercial real-time PCR assays. Dr. Halliday has just introduced 3 commercial assays. They are Aspergillus, mycogene, and fungiplase. And they all have a CE-IVD certification, and they detect the environmental resistant gene, that is TR34 and TR46 related resistant gene. So if we cannot detect resistance due to patient-acquired resistance. Yeah. Another issue to mention is that although the molecular detection of azole-resistant mutation directly on clinical sample is promising, but unlike ITS, which is a multi-copy gene, the C51A gene is a single-copy gene. So if the fungal load in clinical sample is very low, it will not be possible to detect the azole-resistance. And MultiTOF is another potential technology to detect azole-resistant Aspergillus. It can detect azole-resistant Aspergillus by accurate species identification and or by determining the minimal profile change concentration and PCC. Based on the microbial mass spectrum, the MultiTOF can differentiate species, including those encrypted species with intrinsic azole-resistance. Besides, MultiTOF can measure Aspergillus stability by detecting proteome modification in the presence of antifungals. Briefly, fungals to determine NPCC, fungal suspension was added into voriconazole solution of different concentrations. After incubation for up to 2 days, the fungal materials were processed and the supernatant were spotted onto the MultiTOF target plate. And the protein profile of Aspergillus co-cultured with voriconazole are analyzed by MultiTOF. And the study result shows that MPCC is defined as the Lloyd drug concentration that alter the microorganism protein file. So we can get a MICC value. And study result demonstrate that there is a high agreement between MIC determined by CLSI post microdilution method and MPCC by MultiTOF. So this proof of concept study suggests that MultiTOF has the potential to detect azole resistance in Aspergillus. Okay. So because reference MIC testing is usually not a clinical routine, so it is important to catch some clinical clue or phenotypic clue to detect azole resistance. Clinically, if azole resistance should be considered in patients not responding to azole treatment or had breakthrough infection during azole treatment. From a laboratory perspective, the phenotypic clue for resistance including atypical growth and isolate producing yellowish pigment. And for atypical growth, we can see that patient azole-resistant fumigators due to patient acquired resistance, their colony will show abnormal colony morphology, like lack of sporulation or reduced growth rate. For example, these two voriconazole resistance is recovered from a patient receiving voriconazole for 3 months. And the growth rate and sporulation of the resistant isolate has apparently reduced, giving the colony whitish and small appearance. So this is the typical appearance would be a hint for a patient-acquired resistance. And the other example of a typical growth is Aspergillus lentilis. Aspergillus lentilis is intrinsic resistant to azoles, and on microscope it looked exactly the same as the air fumigators, but Aspergillus lentilis, the sporulation is apparently impaired, so the colony look whitish, appear whitish. So for Aspergillus-like colony, but with whitish appearance, we should consider Aspergillus lentilis. And Aspergillus calydosus also intrinsically resistant to azoles. It produces yellowish pigment, which turn the median yellowish. So for isolate, which produce pigment, yellowish pigment, especially when it is recovered from patient with azole exposure, we should consider Aspergillus calydosus. Okay, the final slide for today. Oh, yeah, so the important Aspergillus to be mentioned include air fumigators with acquired resistance, and Aspergillus lentilis and with calydosus with intrinsic resistance. And indication for testing azole resistance, including epidemiology surveillance, and for isolate recovery from patient group or region with known azole resistance or not responding to treatment. A method for stability, including azole agar screening test first, followed by reference MIC testing using UCAST or COSI method, or alternative by EAST-1 or E-test method. We can also use molecular detection of azole-resistant gene, and commercial assay is available. MultiTope has a potential to detect azole resistance, but still needs optimization and standardization. And in Taiwan, the azole-resistant Aspergillus, the prevalence is still around 5%. So azole-resistant testing for Aspergillus is not a clinical routine. But our guideline does suggest that we can preserve the isolate for future anti-susceptibility testing in case of treatment failure. Maybe this would be an alternative way to deal azole-resistant aspergillosis when susceptibility testing is not a clinical routine. Thank you very much.